Okay, good afternoon. Welcome to this session sponsored by UrgoMedical. So today we are going to be talking about gentle yet effective ways for slough removal with medical devices. Okay, and I hope it's an interesting talk because we have tried to mix science along with clinical. So I'm a scientist by training. My name is Debashish, and I'm the head of medical affairs for UrgoMedical. Are you getting a lot of feedback? It's okay. So I'm a chemist by training. So some of the discussions I do will be a little bit chemistry heavy, but in order to make it interesting, we have two clinicians on the stage here, Dr. Kristen Murphy and Michelle Labbie. I'm going to save at least 10 minutes of my time in not having to introduce them because they're so well known, and I want to thank them. So let's get ahead with the presentation. That's Dr. Murphy, and she's on the stage with you, and she's going to be speaking about chronic wound dilemma, and take it from there. Go ahead.
Thank you, and a lovely topic for lunchtime, some nice pretty pictures. Thank goodness we're all wound clinicians, right? Hopefully the food is good there, it looks pretty nice. So we're going to start out by just reminding ourselves about the issue of the chronic wounds. You know, we've just heard from the government just in the last 24 hours about the chronic illness and how that's going to be taking over our healthcare systems in the next few years, although we're already feeling the impact. But of course, we all deal with these chronic wounds that are not yet identified as part of this problem. Chronicity, of course, why are these wounds chronic? We've all been taught that these wounds are stuck in the inflammatory phase, when in fact there's this hyperinflammation that's actually going on. This hyperinflammation we now know is driven largely by biofilms. So once we know that why this is happening, we can address this. Of course, dentistry have known this for decades. They've known about gingivitis. We all have been informed, educated that we must clean our teeth, brush our teeth to manage this thing called plaque. This thing called plaque is in fact biofilm in our mouths that is there all of the time. Bacteria will automatically form these biofilm colonies. This is their preferred way of being. And so we see this in our mouth. And if we don't address this in our mouth, of course, we get this inflamed gum, this gingivitis. So, you know, we can't just rinse our mouth with water and call that dental hygiene. We can't just come to conference, have forgotten our toothbrush and our toothpaste, and think that we've got the job done. We're going to feel that irritation until we get the job properly done. And the same thing is going on in wounds. So, you know we use mouthwashes to retard biofilm regrowth. After we've cleaned our teeth, we can use these kinds of products so that things slow down so we don't have to be constantly brushing our teeth. And every once in a while, we go to our hygienist and we really get in there and they clean all the nooks and crannies for us because biofilm is never completely gone. And so we can optimize the environment so that our gums are healthier, so that we don't have so many problems. And we have to think about how this parallels with wound care practices because we have the same issues with biofilms in these wounds that are not progressing that we all deal with. So if we compare this, if you look at routine cleansing in dentistry, we'll be clean with toothpaste. I'm sure everybody's done that this morning. But with wound care, we need to use a cleansing solution. We need to actually, to manage the biofilm that's in wounds, we need to use a cleansing solution. Water, saline is just simply not enough. We need to physically remove, we get the toothbrush in there. You don't just kind of rinse with toothpaste or mouthwash and call it a day because you feel like kind of fur on there, right? So you need to clean with intent. Same goes for wounds because you physically need that removal. And then you want to retard till the next cleaning. So you'll use toothpaste and ingredients and mouthwash ingredients to do that. And in wound care, we have advanced wound dressings that will slow down the regrowth of bacteria. And then we want to optimize the health because we want to prevent problems actually occurring. So we may go in and we may have professional cleanings by the hygienist. And anybody that knows me, I advocate for wound hygienists. We should actually have programs for this. And In wounds, sometimes you need debridements, and sometimes they need to be surgical to really get the job done. And then to promote that environment, in dentistry, they have things like fluoride treatments and sealants. I mean, this has been established for decades and decades. And in wound care, this is where we go to our advanced products like negative pressure, collagens, extracellular matrix, and things that adjust the pH. So, to try and make this a bit more intuitive, I mean, we as clinicians understand what needs to be done. We study things like nerds and stonies and upper and lower and what goes wrong and unhealthy granulation tissue. But when we're dealing with our administrators and our politicians and people that fund our programs, we really need to clarify the language. I'm a big proponent of this. And so one of the ways we've done this is we've proposed that we consider this as wound gingivitis, if you may, because this is simple. Everybody understands this concept. We call this granulitis. We can go to our people who fund us, our administrators, and say, we have this problem with chronic wounds, these hard to heal wounds, actually. If you give us the resources, we can actually manage this. And actually, it's very similar to dental hygiene. We need the resources, the appropriate the dressings, the solutions, and all of that kind of thing. We need the appropriate supplies and also the appropriate people to provide hygienic measures to deal with this wound granulitis. This is a much simpler way of explaining things to people who will fund us, which is an important part of what we do. And in fact, there are many guidelines that support this idea of proper wound cleansing. So the pressure injury group, the wound hygiene group, and I'm going to invite you to come to the session on Saturday morning about that. Wound Infection Institute, International Wound Infection, and so on. So many people agree that you've actually got to clean these wounds because the science is there. Now, unfortunately, traditionally, we've been sort of told that, well, it's not cost effective to use cleansing solutions. Saline is cheap, sterile water is cheap. So where's the money going to come from? Well, I invite you to think back to when the hand sanitizers came in. I can remember thinking they're never going to pay for these hand sanitizer things, right? I mean, soap and water is right there and it's cheap. Having a sanitizer little thing at the end of every bed in the hospital, that would be so expensive. But guess what? It happened, right? Hand sanitizers are everywhere because it works, because it reduces infection. And so we need to get the message out there that you actually need wound cleansing solutions to properly do the job. So when you think about a wound cleansing solution, what are you going to pick? Well, what attributes does it need to have? Well, it needs to be effective at getting rid of those pathogens, right? That's why you're using it. You want it to be effective. You want it to not be cytotoxic. You want to make sure that you're not killing the healthy healing cells and the components that need to actually be there to rebuild that tissue. And you want to make sure that the pH range is right. And we're all very familiar with, the acid mantle on the skin. And why do we have this acidic mantle on the skin? Well, it's to reduce the likelihood of infection should there be a breach, right? The skin is a little bit acidic so that if there is a breach, any bacteria in the area are less likely to have a nice home there. And this is the same thing with the open wound. We want this little bit of acidic pH so that bacteria are less likely to grow, multiply, and cause infection. Is it suitable for use every day? You wouldn't have a toothpaste that you can use once a month and expect that to prevent gingivitis. So you want to have something that's suitable for regular use. And is it improved by dwell time? So you want solutions that are reasonably effective at a short dwell time, but do think that they may need dwell time. And if you think of soaking your dishes, with that stuck on stuff, plaque is very tenacious. Biofilm is very tenacious. If you have a wound solution that soaks there and can release some of the debris and some of the bacteria, it's going to be more effective. And you can usually put these soaks on while you're getting your dressing tray and everything prepared. So again, the guidelines agree with this. You want a solution that will kill both planktonic and biofilm bacteria, but it won't be cytotoxic to the healing cells. And you know, hypochlorous acid is something that our body uses anyway. When the neutrophils that attack the bacteria, the pathogens in your body, when they go and they attack those pathogens, what they do is they engulf the pathogen and they fire hypochlorous acid at it. We make hypochlorous acid in order to kill the bacteria in our own bodies, which is a very effective mechanism to destroy bacteria. And it's effective against bacteria, drug-resistant bacteria, viruses, fungi. We know that, these are also implicated in biofilms now. And we know that it actually is very effective within seconds. Now, having said that, the soak time is important because biofilm can be thick. So you've got the surface ones, but you want to give it time to be able to kill properly in your wounds. And people have looked, so Day and colleagues have looked at comparing saline and chlorhexidine and Vashe solution to see how effective it is against Pseudomonas and MRSA. And what they found is that chlorhexidine and Vashe were very effective, significantly reducing the amount of these bacteria biofilms in the wounds. Saline wasn't, but what's the problem with chlorhexidine? It's cytotoxic. Yes, I heard that. It's cytotoxic, absolutely. So you don't want to be using that. And then there's been this new paper that's just come out talking about the idea of surfactants versus antiseptics as an approach to biofilm management, finding that the antiseptic solutions are much more effective at reducing biofilm than a surfactant alone. So you really do want that antiseptic type solution. And, you know, when you look at the wounds in this study, you can see the images here under the fluoroscopy light that some of you may be familiar with. This is a saline-treated wound. And what they actually found is with wounds were treated with saline, the bacteria increased. And this is most likely, they said, because when you clean with saline, you're actually revealing the deeper bacteria underneath without killing anything. So you're moving the surface covering, if you will, and revealing what's underneath. So it's not that saline makes bacteria grow, it's just revealing what's underneath, but not killing it. But then if you've got more bacteria underneath, they could potentially proliferate, right? So you want to be dealing with these bacteria. And again, we want antiseptics, not just the surfactants, the soap, if you will. The saline and soap is not as effective at all. So how are we now going to decide then which antiseptic solution we should use? What is it when we have to come down to which solution we should use? We want to look at cytotoxicity. Is it cytotoxic? If it's the old school stuff, that's cytotoxic, that's not the best practice anymore. All of the recommendations agree on that. Does it have debridement properties? So now some of these solutions will have debridement properties and they can make this claim. You can go into the exhibit hall and you can talk to people about that. But does it release the slough? Does it actually enable it to be pulled off more easily so that you now can reveal the healthy granulation underneath and improve the wound bed environment so that the healing cells can move where they need to? And the pH, again, as we talked about acid mantle, is it a little bit acidic? Is it giving it the right pH so that the healing can occur and the bacteria don't want to make a home there so easily? There is a new consensus document for wound debridement, and this does suggest now that Vashe can actually debride. It has debridement properties. It does loosen the slough. It does free it off for removal so that it's now more easily done because we don't all have access to sharp debridement in our practice. It has a safe therapeutic index range, and there was a group recently, including Sybil and our dear departed Gregory Schultz, who wrote a paper quite recently talking about therapeutic index of these solutions. And that has to do with their cytotoxicity and their effectiveness at killing bacteria. And the higher the therapeutic index, the more safe and the more effective it is. And hypochlorous acid was found to be the best solution as far as Pseudomonas, staph aureus, and also E. coli. So it's very, very, very useful for that, and I invite you to read that paper. So Vashe is a debriding cleanser. It's useful for cleansing, for packing, and for soaking. So you do want to soak it if you have those really tenacious, difficult wounds. It can be used with negative pressure therapy with installation. It can be used alongside other debridement methods. And so our surgeons, for example, will always soak with Vashe, sharp debride, and then they will cleanse with Vashe afterwards. They first of all want to remove any bacteria that they might sort of inoculate deeper while they're debriding. So they want to clean first, then they debride. And then after they've debrided, they may have released some biofilm bacteria, woken them up, if you will. And we know that we don't remove all biofilm bacteria by debridement, so they want to kill anything that's revealed afterwards. It has been used with ultrasonic debridement, and I've used it for pre and post soaks, but other people have actually used it as the coupling agent with good effect, and it's safe for use with cellular and tissue products. Again, minimize harm. These bactericidal agents mustn't be killing the wound cells because we need those cells to proliferate. And we know that some of our traditional solutions that are still in use do in fact do this. They've tested, at length the safety of this. And as I mentioned, the body makes it itself, so it's pretty safe stuff. But in a stable solution like this, it doesn't interfere with even eye irritation in the rabbit and so on. You can see for yourself all of these different impacts that they have tried, and it's very, very safe. It's non-mutagenic. And if you look at the grading, so here we've got 0 being a good grade, that there is no cytotoxicity. Hypochlorous acid, 4 times the strength. You wouldn't use it at 4 times the strength, but 4 times the strength still isn't cytotoxic. Of course, saline isn't, but all of these other solutions do fail on that aspect. Just very briefly, I'm showing you can't really see, I don't think, in this picture as well as it shows on my laptop, but this is a hypergranulating, so unhealthy granulation groin wound that we treated with the Vashe soaks to, again, manage biofilm. Don't forget that whenever you see hypergranulation, that's too much moisture and it's bacterial overload together. We may manage to get this healed up with that. We did a cleansing with the Vashe solution, vigorous 10-minute soaks, refashioned the edges with a curette, and we used an anti-biofilm hydrofiber dressing on this one. The ultrasound debridement is something we used a lot in our practice to clean that out and get rid of the biofilm, and then use a dressing that will, again, help debride and release. We always use Vashe when we do this. And here's a very devastating posterior heel that they've had their bone removed. And you can see that's very deep. These ones often go on to high above knee amputation. We treated this with negative pressure therapy, and the Vashe soaks are a critical component of this, leading up to skin graft closure. And again, making those wounds in great circumstance, bringing that granulation tissue, removing dealing with the granulitis, removing the unhealthy tissue, using a cleansing and a cleansing debridement solution to get your wounds down to healthy status, then we can often close these surgically, and closing them surgically is a way that we often will go. You need to know your limits. A solution's not going to do everything. Know when to refer. And with that, I'm going to move along to the next speaker.
Okay. Anyway, just to continue on, and we're going to move into looking at debridement and some different ways of debridement and some different technologies, specifically UrgoClean Ag that has come to market in Canada. So our traditional current debridement methods are sharp, traditional autolytic, mechanical, and the use of ointments like enzymatic debriders. We know, and this is supported by the literature, that microbial colonies will reestablish or start being established within 24 hours of debridement. And we know that slough in a wound is food for bacteria. We know that more frequent debridement leads to better outcomes. If there's sharp debridement or debridement done one or more times a week, the outcomes are much better than if it's less than once a week. And autolytic debridement alone is not enough. We need to add to that. That is, autolytic debridement isn't enough as supported by the wound hygiene concepts. And so we need to be more aggressive, is the best way to say it. So continuous debridement, I postulate, or Urgo postulates, as another way of debriding a wound. Continuous debridement through physical interaction with the wound. This needs to be effective, accessible, easy, and comfortable. And UrgoClean Ag is a negatively charged dressing that supports the debridement of slough. It is an antimicrobial, having silver in it, and it's made of a TLC AG matrix, which I'll let Dr. D talk to you about. It's fast and effective, and it works on biofilm. So it is another tool for us to use to move wounds along through the process of healing through continuous debridement. So I'm going to let Dr. D talk to you about how charged fibers work.
Thank you so much. Before I do that, I want to acknowledge certain points that Dr. Murphy made here. Number one is granulitis. This reminds me of the word biofilm, which was floated in the context of wounds by Jim Costigan, a really famous microbiologist in, I think, the journal's Nature of Science. And people looked at that word and said, what? Makes no sense. Look at where we are now. We now understand the root cause that biofilm is that delays wound healing. So the word granulitis should take on, will take on, and I urge all of you to think about it as a disease condition of granulation tissue. So really important work. The second thing is the paper that has just been published on the danger of saline. I have somebody sitting in front to who I propose I should say saline is dangerous. Saline is dangerous? That's a provocative statement. But she said, go ahead and say it. Now I'm saying it based on the data that Dr. Murphy just showed. What I want to say, a better way to say that, non-provocative way to say that would be, if you know when you're cleansing with saline in a chronic wound and you're depositing germs from the peri-wound into the wound by cleansing with saline, it should give you thought. It should give you pause. And in that context, saline is indeed dangerous. There's a second point I want to make. The third point I want to make is the debridement issue with hypochlorous acid. This is proven, and Dr. Murphy didn't talk about it, but she has written a paper recently on how to make hypochlorous acid debride the best with negative pressure wound therapy. We have a series of lectures that we will be having that will be led by Dr. Paul Kim in the new year about how hypochlorous acid should be your preferred choice for negative pressure wound therapy. 3 points. So please note those. Now, UrgoClean Ag, this is going to be a quick interactive session. How many of you are not aware of this product? How many of you do not know about this product? A fair number? Okay, we'll talk about it. How does it work? Let me tell you the chemistry behind it. The first 3 bullets of steric exclusion, hydrophobic, blah, 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 that is chemist talk. Every dressing does those things to remove some degree of slough from the wound. But what UrgoClean Ag does particularly well is the electrostatic interaction. It's almost a magnetic effect between the dressing and slough. How does it work? It is a negatively charged product, but it's not unique in that respect. Truly, alginates and carboxymethyl cellulose also have negative charges on them, but those charges are far apart from each other. As you can see, those green circles are rather far removed from each other. Look at the green charges on UrgoClean Ag. They're cheek to jowl. They're next to each other. So the charge density is very high of these negative charges. And this is what makes this dressing special. This is the engine of the product, not the silver. The silver is just providing some antimicrobial barrier effect, but the negative charge is what drives it. You can see this in a very simple experiment in the lab. And all we did was we created fake slough, and we added an alginate on top of that, or a CMC-based product on top of that, or UrgoClean on top of that. And when we remove the dressing, the alginate and the carboxymethyl cellulose cannot pick up that fake slough, but UrgoClean can. This is lab data. We see this also in practice, and Michelle is going to be speaking about it at length. So I want to talk about hypochlorous acid again. Why? Why am I switching back and forth between the two? This is a quite famous graph that explains how hypochlorous relates to its evil cousin, hypochlorite. You know about Dr. Jekyll and Mr. Hyde? That's hypochlorous and hypochlorite. Good versus evil. So the blue line shows that at a particular pH in which Vashe is created and stabilized, most important statement, the parts per million of Vashe will remain stable over time. It is stabilized at that range. It makes sure that the product remains as the good between the twin, Dr. Jekyll, and Mr. Hyde, which I believe is the evil, is this Dakin solution because it's hypochlorite and highly cytotoxic. So the pH of Vashe is very similar to the pH of intact skin, and that tells you something why this pH is important. But at the request of many clinicians who get confused, I don't blame them, between hypochlorous and hypochlorite, we are trying this new visual. I'm going to ask all of you whether this makes sense or it sucks. You should take a look at this. That is the famous equation between hypochlorous and hypochlorite, and it's got a double arrow because it can go either way. It can be Dr. Jekyll or it can be Mr. Hyde. So remember, wound pH can exist between 4-ish to 9-ish. An acute healing wound or a healing wound is about pH 4. The alkaline pH is associated with chronic wounds, okay? Now, this is what happens when the wound pH changes, or the equation changes from low pH to high pH. Look, it's going from the green to the red. And as soon as it goes to the red, the hypochlorite predominates, okay? So a solution that starts acidic and becomes alkaline is dangerous because it's going from good to evil. Watch what happens when we change the pH on skin. This is a real life case. In this case, the wound presented like the panel on the right-hand side with a big lesion on the bottom of this person, which happened due to fecal and urinary incontinence because of high pH. As the pH was changed, how was it changed? Look, watch for the arrow move. Watch it move. It was changed with Vashe. The skin pH was taken from alkaline to acidic, and the wound healed. Now, there are other factors at play, and it's a very simple graphic. But what I'm telling you as clinicians, you have the power to control the pH of the skin, and please use that power. Now, how is this relevant to UrgoClean Ag? This simple diagram tells you how, okay? Look at the blue line. There's a wound bed, and it goes from pH 4-ish to pH 9-ish. And that nasty looking wound is on the right-hand side, so it's high pH. The dressing, which is on top, per my graphic, that's why it's on top, it's always negative in charge, always negative. The dressing is always negative. The wound can be positive or negative, depending on the pH. So the slough can be positive or negative. If the wound is chronic and the pH is high, then the slough is likely negative. And you probably don't get the best out of UrgoClean Ag. But see what happens when you use Vashe. You force that slough and the wound to go to the positive side, and then positive and negative attract. This is what the graphic means. Now, is Vashe 100% necessary for UrgoClean Ag to work? The answer is no. In fact, the randomized control study that we published that shows 50% higher rate of debridement of slough compared to the hydrofiber product did not use Vashe. And one of the biggest studies in the world on silver, on nearly 2,500 patients, did not use Vashe, yet we saw excellent results. But what I'm trying to tell you is that if you invested in UrgoClean Ag, you can absolutely augment its slough removal or debridement properties by pre-soaking with Vashe, just like Dr. Murphy said. I'm not going to talk about this because this was covered by Dr. Murphy. What about biofilm? We have got a really high-level study that's showing UrgoClean Ag is able to remove biofilm to a huge extent. Now, as a scientist, I tell you, is it the negative charge that's doing it or something else? I don't know the answer to that. I'm just reporting the results as we see, but I'm not surprised by it. So to tie it all together, I hand it over now to Michelle Labbie. Thank you.
So I'm going to talk about clinical experience with UrgoClean Ag. I need a clicker. So this is my disclosure case study. So this was a case of severe frostbite. This fellow changed a tire in -30 and fainted. I called passed out in the ditch. And so he ended up with severe frostbite, and we decided we were trialing UrgoClean Ag. We decided to try it on one finger. And so we did it on his ring finger. And 4 days later, took it off, and you can see all the stuff that comes off on the dressing, and we had improvement in that wound bed. The rest of the dressings we changed daily. So when we look again, I talked about undisturbed wound healing previous to this. It gives us the ability to leave those dressings a little longer to support debridement and also to support biofilm management. So 19 days later, we were still using it regularly. We did add on to the ring finger, but you can see the amount of drainage and wound garbage that collects on that dressing. And then this was about 1 month later. And of course, if you deal with people with frostbite, you know that these wounds take a long, long time. He didn't end up with any form of amputation of any of his fingers, which was very positive. So addressing the infection and biofilm was an important part of that, because we know the body decides what lives and dies. We did try it on a skin tear, and this was a fellow that came in with a skin tear. You can see that it had been left to sort of open. It was kind of open and weepy. And honestly, we put it on. We covered it with a semi-permeable film dressing, and we left it. It was changed once in 11 days, and we had full closure with just a little bit of scabbing left. So very simple to do. UrgoClean Ag is non-adherent as well because it has that lipocolloidal silver matrix to it. We did a number of venous leg ulcers. This was a fellow who came in and he had been weeks and weeks and weeks without treating his legs. He had numerous wounds. We decided to try UrgoClean Ag midway through when we had the dressing available to us. He was in a compression wrap, so those were being changed twice a week. So again, we needed to choose a dressing that would address biofilm, address the drainage, and support that undisturbed wound healing. And at 1 week, we can see that things had cleaned up. It's hard to tell from the picture sometimes, but 3 weeks later, you can see that there's good epithelialization and new tissue that's coming. And again, you can see that as drainage changes, the amount of dressing used is of course less, but it was still atraumatic in moving to taking it off of the leg. Again, another venous leg ulcer with light compression. You know that these can be exquisitely painful. People don't like to be debrided. And so you can see that the amount of tissue or amount of slough that was removed is significant. And I need to tell you that with each of these cases, Vashe is a standard of care in our clinic. So Vashe was always used as a soak. We usually do 5 or 10 minutes. And we'll debride and then soak with Vashe because we do conservative sharp wound debridement. So using the Vashe after to clean up that wound and then to apply the UrgoClean Ag. So we can see good granular formation and decreased slough. This was a lady, honestly, we tried every dressing in the world on her, I'm pretty sure. But she had exquisitely painful ulcers, so she's very reluctant to try anything. She had tolerated UrgoTool Ag, so she would try the UrgoClean Ag, and we had good slough cleanup with her. She was, again, a difficult patient. She's actually having venous surgery now for a feeder vein, but her dressings were changed 3 or 4 times a week with her own stockings. And so we had good response with the UrgoClean Ag. I want to pass along a few tips and tricks as well. Making sure that the dressing is large enough to cover the wound and that the dressing has direct contact with the wound. It needs to have a direct contact. As you know, a wound cleanser, Vashe is a perfect complement to it, and I'll explain a little bit more about that as well. And we did fenestrate the dressing if needed, so if there was excess exudate, it wasn't pooling underneath, so that it could come through to the cover dressing. And that's something we've talked about at the booth, that we need to fenestrate the dressing because we don't always have easy access to scissors. And I've been asked many, many times, how do you fenestrate a dressing? So I actually videotaped it. So it's simply just taking a pair of scissors, sterile is preferred, and just cutting slits into the dressing so that exudate can come through. Now, this can be done with any kind of dressing where you're having to have, there's too much drainage, but we can't just continually stack. We have to look at what we're doing, and this would still require an appropriate cover dressing. Underneath the compression wraps, with those wounds, there wasn't a lot of drainage, so it was just used as the contact and primary dressing, and then the compression over top for wrapped compression. So that's how we fenestrate it. You can do little or less, but it allows better transfer of exudate through. So Dr. D is very technical, very scientific. So I'm going to take the same graph that Dr. D talked to you about, and I'm going to give you a plain spoken Alberta girl's perspective on it. So when we look at pH is very important. We know that we have to look at the acid mantle of the skin, and that wounds that are more alkaline, chronic wounds tend to be more alkaline, are more likely to have biofilm and bacteria. So the more alkaline, the more problems we have with biofilm and bacteria than we would at a normalized pH. At those higher pHs, the slough is negatively charged. And so if we can move the pH down to within a normal healthy range, the slough will become more positively positively charged. And we know that positive and negative always attract one another. 2 negatives don't attract very well or for a very long period of time, but we can have, when we have negative and positive there, it sort of supercharges the UrgoClean Ag so that we have a very good interaction and better pickup of the slough because of the ion exchange. And so by using a wound cleanser like Vashe, where we can bring the pH down, we have better efficacy of the dressing. And so that's sort of how I explain that. So we wanted to save enough time to answer questions because there's usually a lot of questions around this, you know, a new dressing and cleansers.
Right. Listen, we got to have some fun post lunch. This graph is interesting because not only when you use Vash, you charge the slough as you make it more positive, but it also works on the necrotic tissue. So it makes UrgoClean Ag's job a bit easier. That's a way to look at it. Now, I just want to ask, I showed you those graphs, Dr. Jekyll and Mr. Hyde, with the needle moving from right to left and left to right. Does it make sense? How many of you think it's a good graphic to explain how hypochlorous and hypochlorite are related? Show of hands, is it an effective visual? It's difficult to poll. Come to our booth, and if it really didn't work for you, I want to hear from you so we can improve upon it. So there are some microphones here. If you want to come up and ask the questions live, we can deal with it. Okay. The first question, I'm just going to take it from here. It says, what is the recommended dwell time? I can tell you our preclinical data shows that anywhere from 1 to 5 minutes is good. 2 minutes is better than 1 minute. 3 minutes is better than 2 minutes, but 7 minutes is not better than 5 minutes. It's a law of diminishing returns. How do you do it, Michelle? How do you want to say that?
How do I want to do it?
How long do you dwell?
When we're doing our soaks, we'll do 5 or 10 minutes. It's basically putting the soak on. I prefer to do it after you debride and then get everything ready and then come back to it. And I wanted, can I ask a question? Sure. So before I get to go first. Is this a biochemical reaction or is it a physical reaction? What kind of reaction happens between UrgoClean Ag and the wound?
Yeah, that's a great question. In fact, it's one of the questions that I see here. How does it really work? Listen, the effect is not biochemical between UrgoClean Ag and slough. I like to say in joke a little bit, like many human relationships, it's purely physical. It's purely physical, okay? So just keep that in mind. That's how it works. It's not biochemical at all because it's a medical device. And it works through attractive physical forces. Thank you. Let's take the next question. Could you please provide reference for Dr. Sibal's recent research article? It's in the Advances in Wound and Skin Care. And if you come to a booth, we'll tell you where it is. Please go ahead.
Do you need a physician order to use those products, or is it covered under the provincial skin and wound guidelines?
Do you need, in Alberta, you don't need an order for it. It's not a prescribable for Vashe or for UrgoClean Ag. It's just part of contracting and formulary, right?
Okay.
And so that's that. Then this question.
Hi, I'm Heather. I just have a quick question. I might have missed it in the presentation. What's the parts per million of silver that's in the dressing?
Yeah.
I think we describe it as milligrams per square centimeter, and I think it's 3.22 milligrams. It comes roughly to around 50 ppm. Okay. Yeah. So it's ionic silver, and that level is sufficient to provide barrier function within the dressing.
Thank you.
There's a.
Hi,
Let's get the live question.
Hi, I'm Simone. So within the healthcare system here, you probably would use it as part of your program, but if it was private, what kind of added cost would that be to that specific wound management?
I could not hear.
The cost.
It truly depends on where you're getting it. So right now, if you go on to Amazon, you can buy Vashe there. So it depends on where people are getting it. If it's a pharmacy or a medical provider, how much the markup is. It really depends. And you can talk from there, Christine, it's on.
It's provided by our home care.
Yeah, so
It's
we
on
have.
formulary, so we don't end up.
So in Alberta, home care doesn't support the use of Vashe, so we have to get people to buy it. And they go on Amazon and it's delivered the next day. So you can do that. So really, it's a big depends, right? Where you are, what province and how you're getting access to it.
So it's more expensive than saline though, so
So
it
then
would be a
yes.
hard, yeah.
Well,
Okay.
yeah, and it is more expensive than saline, but gauze is also cheaper than a lot of dressings, and we don't use that anymore.
And I
Right.
would say, going back to the point of the hand sanitizer, right?
Exactly.
If you look back several years, we didn't think anybody would fund that, but they did because of the infection. And this is going to be the same thing with wound cleansers.
Hi, I have two questions. I'll try to make it brief. One of them was when you were talking about when you soak with the Vashe and then after it said vigorous scrub. So are you talking like, because normally if I put a Vashe soak on, I'm just putting it on there for 15 minutes. Like what was the vigorous like scrub?
Yeah, the audio for these questions is not great.
It's okay.
You're not soaking the foam with Vash.
No, they're soaking the wound for 15 minutes.
Yeah,
Fantastic.
Yeah.
And then we, like I say, necrotic tissue and biofilm ain't gonna remove itself. It may be
Yeah.
broken down. You need to use a little bit of elbow grease,
Well, you wash your hands.
just like you wash your hands.
okay.
And the point is, when you use saline, people do the right thing with scrubbing, but they're not doing anything to the germs. They're just helpfully for the germs, taking from the peri-wound and putting it in the center of the dressing. After you're done with your scrubbing, the hypochlorous acid has a very short half-life. You can put your favorite dressing on top of it, whether it's polyurethane foam, whether it's gentian violet, whether it's iodine, whether it's an enzyme. You can do whatever you want. Yes.
Say to that too is, if you think about soaking your dishes, you've got something already stuck on, so you soak them in some soapy water in your sink.
Mhm.
Then you take the dish brush or whatever the scrubber is and you scrub the stuff off, right? So that's the agitation part of it. So what you would use is you've just soaked it with saline soaked Vash. You would just take that saline, that gauze that you soaked, gauze soaked Vash. You take that gauze and you would just agitate with the gauze that's in place. Again, you have patients, not dishes, so you want to have them on board as far as you're not torturing them. You explain to them what you're doing, etc. You get consent, all of that stuff. But you want to agitate, because if you just soak your dishes and then you don't use the scrub brush, it's not going to be as effective as if you agitate.
And I
That
think the
makes
important
sense.
part is using a gauze to do it, not a curly Kate, not a nail brush. And I've seen that too. People saying scrub, it is scrubbing, and it's remembering to do the peri-wound and the wound edges as well. You can remove a lot more than
Okay.
you think.
Thank you. I just have one more quick one. We were just wondering, with the biofilm, are there any tests after, like testing, I guess, with the biofilm after you've used the products? To
Not
see?
really. There's,
So no, I don't test after I brush my teeth either. The kids have those little colored tablets or whatever they use once every 5 years to just show that they're doing it properly. But for regular use, you don't need to. You know it's there. You know you're cleaning. You know it's going to be better. You can see it.
Yeah, in some rare places, they have this handheld device called Moleculite. And with that, you can actually see whether you remove the germs or not. But it's not available everywhere. Let me get that question and I'll come to you in a second, please.
I'm just curious if there's any difference between the Vashe and the BioCell, that is the other
yeah.
product that's similar to that has the
I can
0.033%.
answer that one. 0.033%. The one that's made in Alberta.
Right, okay, go for it.
Can I go for it? And you'll.
Yeah.
And I also
So-
was wondering, for resource poor areas, can we trust the stuff out there on how to make Vashe?
Okay, those are really good questions. And my challenge would be between Vashe and BioSeal is BioSeal needs to prove the stability of the product. It may be what they say when you first open it, but hypochlorous acid is very hard to keep stable. It splits those molecules very easily. So as soon as things start to change or it becomes a little more alkaline or unstable, they'll split and you'll get hypochlorite. So it's at what point and how long the stability is. And I've read the things about making hypochlorous acid as well. Now, if you were to follow a recipe and use it immediately, first of all, you would have no idea really what you made or how effective it is or how long it would be stable for. So if I was able to make it on Survivor and use it on on a wound, sure. But we can't do that as health professionals. That's not something we can support as safe practice. But the stability is the key to that. And I'll let Dr. D expand on that because it's very hard to keep hypochlorous acid stable.
Yeah, I think, we are in the position as a company of being a pioneer in this space. And when you're a pioneer in this space, it is flattering to see competition. And it's good. We welcome it. I think just like all silver is not the same, you got to remember that all formulations of hypochlorous acid is not the same. It's common sense. What you need to look for is a body of evidence published over many years in all kinds of settings: acute care, chronic care, venous ulcers, diabetic ulcers, not on a hypochlorous acid formulation that is not specific to the product. So you must look for example, if you're looking for evidence on a hydrofiber with silver, you look for evidence on a particular brand. And if you don't find that evidence and you're reading the evidence about another silver product, those evidences don't apply to each other. Got to keep that in mind. What we can say, what is true for us, is that the product only contains natural ingredients. It's hugely effective and it's heavily researched. And, so that's what we'll say. So you have to make up your mind based on the evidence that you see for any other product in that space. Keep in mind, stability is important. And we have proprietary technology that builds stability into the product. Sorry, you've been very patient. Thank you.
I was just going to ask, if a wound has biofilm that almost looks like a slime, do you have any suggestions how to, do I leave it on longer? Do I do more vigorous scrubbing?
Yes and yes.
So how long and how often? Some suggestions?
Yeah, so you leave it longer, do a bit more rigorous removal, and you might even need to go to a sharp debridement, maybe with a curette, or it depends on your team, but they may need to go for a sharp debridement as well, and it's all going to help together.
But 15-minute, put it on and then do
Well,
the
and if
vigorous-
you're putting it on for a soak and then you're scrubbing, you can always turn it over and let it soak longer. And that would be a really good indication to also start using UrgoClean Ag if you have it, because then you're potentiating that until the next dressing change, right? So there's a number of things that you can do because we know that slime comes back real quick. And so using an antibiofilm dressing, can I call it an antibiofilm dressing?
Sure.
Is effective. And I think, so does that answer your question?
Well, can I do that with a vac then if it's a deep pressure? Because I saw something about instilling with a negative pressure.
Yeah, Vashe can be used as an instillant. And actually, if you go to the booth, they have the Vashe, they have the ones that go on the machine. Like it's for instilling for negative pressure. So it's definitely go there. If you're also interested in those new debridement consensus documents, they have those in paper form at the booth as well. So they're good questions to ask at the booth, but you'll see those installation bottles there.
Okay,
They
thank
come
you.
in like liters.
Say that with negative pressure therapy, even if you don't have the installation version and in the community, often it's not available, using the soak along with the negative pressure, that works really well.
Do you mean leave it in the wound or leave the
No,
gauze?
when you would soak it at change. Whenever you're changing it, give it a good soak then. Yeah, and clean, yeah.
Do you see here?
Well, we have a.
Yeah.
Let me just talk about the soaking issue. If your patient is on the post-acute or the outpatient side, the patient has got to go home. So you can't soak him for 20 minutes, 30 minutes, 40 minutes. You can't do that. In our own experiments, we show hypochlorous acid remains in the gauze if you have soaked it good. How do you know you have soaked it good? When you pour enough, when you pick it up, it should drip. Don't moisten it. It must drip. Okay. In that condition, in the inpatient side, it's quite okay to leave it on between dressing changes, as long as you change it every 24 hours. Because if you don't, germs will come into the dressing and they'll have a party. So it is good to leave it on as long as you want, within the practical limitations that you have in your practice. We can talk about it more in our booth. Yes.
Hi, just a quick question. The ranges that we see for the pH that you listed for Vashe, is that what the pH is inside the bottle, or what the pH range will be inside the wound with the use of the product?
Yeah, that is a great question. Inside the bottle, its pH is guaranteed to be between 3.5 and 5.5. This is the beauty of our proprietary technology, and it'll remain at a high ppm compared to anything else that is out there based on our own analysis. In terms of what happens in the wound is a great question. You could say that the wound is so alkaline, it turns Dr. Jekyll into Mr. Hyde. And what's the point of putting acidic solution if it is going to become alkaline? But the reverse argument is ridiculous, that let's put an alkaline solution in the wound because it's highly cytotoxic. Anything that is alkaline is going to be cytotoxic. We have done a study, and this is about to be published, where we took Vashe, and I've not talked to you guys about it, so you're hearing it for the first time. We put it on wounds, really chronic wounds, and we measured the wound pH. And in most wounds, it remains in that acidic level. In some highly chronic wound, it goes up by an unit of 1, meaning goes from pH 5 to around 6.5, but never becomes alkaline. And then we need to repeat this study with more patients. And that's a great question. If you send us your email, we will send you the study.
Thank you.
Okay, there's many excellent questions. Okay, so do antiseptics like HOCl eliminate beneficial organisms in a wound? Similar analogy as what antibiotics do when treating an infection. Boy, that's a beautiful question. The correct answer is yes, to some extent. But remember, it's not a binary thing. There's a lot of gray in medicine. Acidic pH is more bio-friendly to commensals than to pathogens. So you're not going to make your wounds sterile. That's not going to happen with any non-cytotoxic antiseptic. But slowly, your population or your microbiome is going to move towards commensalic because it kills less pathogens. It kills less bacteria that are beneficial than the bacteria that are pathogenic. This is what our microbiologists, PhD friends are teaching us, but that's a great question. Choose one more.
Choose one more. Do you want to do this one? The
What?
thoughts on Vashe
Well,
versus
why don't you repeat
Anisep?
that question and I'll answer it.
Okay, so the question online is, what are your thoughts about Vashe versus Anisept? I am aware that Anisept is a hypochlorite solution. However, its pH is still 7 to 10. I was under the understanding that Anisept is not cytotoxic. Have you used Anisept in your practice? In our area, that is a solution accessible to us. In our practice, we have used Anisept similarly to Vashe with most of our wounds and found significant improvement with no signs of deterioration.
Okay, that's a long question. Let me answer it this way.
Quickly.
The standards of cytotoxicity keep changing over time. And today's standards, which are International Standard Organization or ISO standards, they really ensure that we are testing by the best methods. Tests head-to-head against the brand that you named shows high cytotoxicity. We have presented that data in public. I can share it with you. It's not surprising because it's roughly 600 parts per million of Dr. Hyde or whoever the evil twin is, which is sodium hypochlorite. And the pH is high. Knowing all that you know and all the publications that exist on high pH effect on wound, you do not want to be using high pH products. That's what I would say. Thank you. Any other questions?
No, I think that's about it. Thank you for your attention. If you have questions, please go to the booth and visit the Ergo team so they can answer those for you. And it's just interesting if to learn about new dressings and to move forward our practice. That's why we're here. And that's why we have access to some really good people to figure that out. So hope lunch was good. And anything?
No,
Thank you,
thank you so
Christina,
much.
Dr.
I
Lee.
want to thank all our wonderful speakers. Thank you so much.